Hi friends, myself Dr. Harish Punia, and we are discussing Tit-bits in neonatology clinical practice, part 1. In this part we will discuss delivery room procedures. So start with the neonatal resuscitation program. Ask 4 pre-birth question to obstetric team. What is gestational age? And amniotic fluid is clear or meconium stain? Baby is single, twin or triplet? Or is there any additional risk factor like RH isoimmunization or foul smell liquor? And ask 3 questions at birth, whether baby cried or not, what is the tone of the baby, or baby is dumb or not. And one more thing is equipment checklist before any delivery is must. For warming the baby, there should be preheated warmer, and warm towel or blanket is also must, and plastic bag or plastic wrap for less than 32 weeker gestation, and thermal mattress for less than 32 weeker. For clearing airway, 10 or 12 French suction catheter attached to the pressure set at 80 to 100 mm of mercury. For auscultation state is must. For ventilating, flow meter sets to 10 liter per minute. Oxygen blender set to 21% in less than 35 weeker. It should be 21 to 30%. And for oxygenation, equipment to give free flow oxygen should be checked, or pulse oximeter with sensor and target oxygen saturation table is also must. For intubation, laryngoscope with size 0 and size 1 straight blade, size 00 for preterm less than 28 weeker, and ET tube size according to the gestational age, and measuring tape and ET tube insertion depth table is also checked. And in medication, injection adrenaline in 1 to 10,000 dilution, and normal saline is checked. For delayed cord clamping, if a baby is breathing spontaneously, then the cord should be clamped and divided until this at least 60 seconds have passed. And if baby require resuscitation, then the cord should be clamped immediately. For initial steps of newborn care, initially provide warm, then position the head and neck, sniffing the morning air position, then clear secretion if needed, only then clear mouth before nose, then dry, and then stimulate the baby by rubbing the back. And the oxygen saturation target, it should be checked pre-ductal. At 1 minute it should be 60 to 65%, 3 minutes it should be 70 to 75%, and at 5 minutes it should be 80 to 85%, and at 10 minutes it should be 85 to 95%. And for algorithm of resuscitation, initially antenatal counseling and team briefing and check equipment, and after birth of the baby initially assess term, tone or crying. If there is no of term, tone and crying, then warm and maintain normal temperature, position airway, clear secretion if needed, dry and stimulate. After then, if baby is gasping or apnea or heartless less than 100 per minute, then give PPV saturation monitoring and consider ECG monitor. And if heart rate below than 100 per minute still, then check chest movement for PPV, ventilation corrective steps if required, and then ET tube if required. If heart rate is still less than 60 per minute, then intubate if we already have not intubated, and give chest compression, coordinate with PPV, give 100% FiO2, and if still less than 60 per minute, then give injection adrenaline, and if heart rate below 60 per minute still, then give consider for hypovolemia and pneumothorax and treat accordingly. And for summarizing, if there is labored breathing or saturation is not in target range, give CPAP, and if at 30 seconds is apnea, gasping or heart rate less than 100 per minute despite stimulation, then give PPV, and at 60 seconds if heart rate less than 100 per minute and despite PPV, then check chest movement and ventilation corrective step is required. And use T-piece resuscitator for PPV because it can give PEEP, and pressure is also controlled. And for chest compression, indication if heart rate is less than 60 per minute after at least 30 seconds of efficient PPV that inflate the lung, as evidenced by chest movement with ventilation. And position, once intubation is completed and tube is secured, then compressor should move to the head of the bed, while the person operating the PPV device move to the side. Advantage of these are, one is providing space for umbilical venous catheter insertion, and other is mechanical advantage that result in less fatigue for the compressor. And depth should be 1/3 of the epidiameter. Size of ET tube and suction catheter according to the gestational age or weight. And premature newborn, if less than 1 kg, then ET tube size should be 2.1 and suction catheter size of 5 French. And premature 1 to 2 kg, then ET tube size 3 and suction catheter 5 to 6 French. Newborn 2 to 3 kg is tracheal tube size should be 3 to 3.5 and suction catheter 6 to 8. And more than 3 kg and infant up to 1 year size of ET tube should be 3.5 to 4 and suction catheter should be 8. And for ET tube position, tip of ET tube should be midway between the vocal cord and carina in the trachea. On X-ray, the tip of tube should be between T1 and T2 vertebral bodies, like in this figure. Position of the lower end should be above the carina, and estimated endotracheal tube length should be weight plus 6, but it is often inaccurate in extreme low birth weight baby, and we may alternatively use gestation based table, and nasal tracheal length may be used. And special precaution for extremely low birth weight babies is first, room temperature should be 23 to 25 degrees Celsius, and portable thermal mattress for under the blanket in less than 32 weeks, and in less than 32 week polythene plastic bag is also arranged. And size 0 or 00 laryngoscope blade and size 2.5 or 3 mm ET tubes to be arranged. And start FiO2 with 30% oxygen in less than 35 weeker babies. And normal umbilical cord length after clamp should be 2 cm before clamp and 1 cm should be after stump. Too long umbilical cord stumps should be avoided, and too short umbilical cord stump after clamp is. And to prevent hypothermia, do routine care before putting baby to mother for skin to skin contact, and thermal control should be a paramount concern, and additional steps should be taken. And temperature at time of NICU admission is a useful quality control criteria for neonatal resuscitation. Thank you.